Welcome to NSG 323, Study Session 9, Problems of Pregnancy. Introduction. Your body has unlimited functions during pregnancy. Occasionally, the changes occurring will cause irritation or discomfort, and in most cases, they may seem be frightening. There is no need to be alarmed. However, you should mention anything that is distressing you to doctor. There are some conditions that arise in pregnancy and constitute problems to the woman and or the baby. They include hypertensive disorder, multiple pregnancy, abdominal pain in pregnancy, antepartum hemorrhage, disseminated intravascular coagulopathy, jaundice in pregnancy, polyhydramnios, oligohydramnios, etc. Learning outcomes. At the end of the study session, you should be able to define and explain hypertensive disorder in pregnancy, enumerate etiological factors for preeclampsia, describe the patients with pre-existing hypertension who become pregnant, list and describe the complications, discuss the prevention and management of hypertension in pregnancy. Gestational hypertension. Gestational hypertension or pregnancy-induced hypertension, PIH, is defined as the development of new arterial hypertension in a pregnant woman after 20 weeks gestation without the presence of protein in the urine. Hypertensive disorders in pregnancy are a major cause of maternal, fetal, and neonatal morbidity and mortality in both developing and developed countries. Hypertension is the most common medical problem in pregnancy, complicating up to 15% of pregnancies and accounting for about a quarter of all antenatal admissions in the UK. Classification of pregnancy-induced hypertension. There exist several hypertensive states of pregnancy. 1. Gestational hypertension. Gestational hypertension is usually defined as having a blood pressure higher than 140 to 90 measured on two separate occasions, more than 6 hours apart, without the presence of protein in the urine, and diagnosed after 20 weeks of gestation. 2. Preeclampsia. Preeclampsia is gestational hypertension plus proteinuria greater than 300 mg of protein in a 24-hour urine sample. Severe preeclampsia involves a blood pressure greater than 160 to 110 with additional medical signs and symptoms. 3. Eclampsia. This is when tonic-clonic seizures appear in a pregnant woman with high blood pressure and proteinuria. HELP syndrome. Classification of causes. A. Maternal causes, e.g., obesity, age 35 years or more, past history of diabetes mellitus, hypertension, and renal diseases, adolescent pregnancy, new paternity, thrombophilias, and phospholipid syndrome, protein CS deficiency, factor V laden. This is a dangerous combination of 3 medical conditions: hemolytic anemia, elevated liver, enzymes, and low platelet count. This is sometimes included in the preeclamptic spectrum. Preeclampsia in addition to pre-existing chronic hypertension. Preeclampsia and eclampsia are sometimes treated as components of a common syndrome. Classification of causes continue. B. Pregnancy, multiple gestations, twins or triplets, etc. Placental abnormalities, hyperplacentosis, excessive exposure to chorionic villi, placenta ischemia. 3. Family history. Family history of preeclampsia. Etiological factors for preeclampsia. 1. Failure to trophoblastic invasion, abnormal placentation. 2. Vascular endothelial damage. 3. Inflammatory mediator, cytokines. 4. Immunological intolerance between maternal and fetal tissues. 5. Coagulation abnormalities. 6. Increased oxygen free radicals. 7. Genetic predisposition, polygenic disorders. 8. Dietary deficiency or excess. Treatment. There is no specific treatment, but is monitored closely to rapidly identify preeclampsia and its life-threatening complications. HELLP syndrome and eclampsia. Drug treatment options are limited, as many antihypertensives may negatively affect the fetus. Methyldopa, hydralazine, and labetalol are most commonly used for severe pregnancy hypertension. The fetus is at increased risk for a variety of life-threatening conditions, including pulmonary hypoplasia, immature lungs. If the dangerous complications appear after the fetus has reached a point of viability, even though still immature, then an early delivery may be warranted to save the lives of both mother and baby. An appropriate plan for labor and delivery includes selection of a hospital with provisions for advanced life support of newborn babies. Definition of gestational hypertension. Gestational hypertension is usually defined as having a blood pressure higher than 140 to 90 measured on two separate occasions, more than 6 hours apart, without the presence of protein in the urine, and diagnosed after 20 weeks of gestation. Complications. Women with hypertension in pregnancy have a higher risk of complications such as abruptio placentae, cerebrovascular accident, disseminated intravascular coagulopathy. The fetus has an increased risk of intrauterine growth restriction, prematurity, intrauterine death. Management. Management depends on the woman's blood pressure, gestational age, and blood flow in the placenta. Non-pharmacological management is recommended for many women, but is not recommended when there is the presence of associated maternal and fetal risk factors. Non-pharmacological management includes close supervision, limitation of activities, and some bed rest in the left lateral position. All pregnant women should receive antenatal education so that they are aware of the symptoms associated with preeclampsia, its importance, and the need to obtain medical advice. Such symptoms associated with preeclampsia include: preeclampsia is gestational hypertension plus proteinuria greater than 300 mg of protein in a 24-hour urine sample. Severe preeclampsia involves a blood pressure greater than 160 to 110 with additional medical signs and symptoms. Women who are at high risk of preeclampsia are usually recommended to take 75 mg aspirin from 12 weeks of gestation to delivery. Such women are those with A. Hypertension in a past pregnancy, B. Chronic kidney disease, C. Autoimmune disease, e.g. systemic lupus erythematosus, SLE, or antiphospholipid syndrome, D. Diabetes mellitus, both type 1 or 2, E. Chronic hypertension. Women should also take aspirin, 75 mg daily from the 12th week if they have any two of the following features: patients with pre-existing hypertension who become pregnant. Review medication and inform the patients of the risks involved with some medications. Those on angiotensin converting enzyme ACE inhibitors or angiotensin II receptor antagonist AIIRAs should be switched from these as soon as possible, as there is an increased risk of congenital abnormalities if these drugs are taken during pregnancy. Ideally, this will have been done at a pre-pregnancy counseling session, but if not, it should be done as early as possible in the pregnancy. Diuretics should be avoided, as they can reduce the blood flow in the placenta. Aim to keep BP lower than 150 to 100 mmHg, 140 to 90 mmHg if there is target organ damage, although do not seek to lower the diastolic level below 80 mmHg. Test for proteinuria regularly. If this shows greater 1 plus, arrange a spot urinary protein, creatinine ratio or 24-hour urine collection to quantify proteinuria. There is significant proteinuria if urinary protein creatinine ratio is greater than 30 mg mmol or 24-hour urine collection has greater than 300 mg protein. Treat the patient as for preeclampsia. See preeclampsia, hypertension with proteinuria and erythema below. Ultrasound examination is used to assess fetal growth and amniotic fluid volume with umbilical artery Doppler velocimetry at 28 to 30 weeks and 32 to 34 weeks. After delivery, if methyldopa is used, switch back to the pre-pregnancy antihypertensive regime within 2 days of delivery. Gestational hypertension treatment. Assess severity. Mild 140 to 149 / 90 to 99 mmHg for patients presenting before 32 weeks or at high risk of preeclampsia. Measure BP twice a day. Otherwise, measure BP number more often than weekly. Check urine for protein at each visit. Moderate 150 to 159 / 100 to 109 mmHg. Monitor BP twice a week. Start labetalol alternatives and methyldopa or nifedipine to keep systolic BP less than 150 mmHg and diastolic BP between 80 to 100 mmHg. Deep urine for protein at each visit. Arrange initial blood test for FBC, electrolyte, renal function, and LFTs. Subsequent blood tests are not necessary if there is no proteinuria. Treatment. Severe, greater than 160 / 110 mmHg. Admit to hospital in a very quiet room. Treat as for moderate above to keep systolic BP less than 150 mmHg and diastolic BP between 80 to 100 mmHg. Measure BP at least 4 times a day and check urine for protein daily. Weekly blood test for FBC, electrolyte, renal function, and LFTs. Check BP and urine twice weekly and continue weekly blood tests when discharged once BP is in the target range. Perform ultrasound examination at 34 weeks to assess fetal growth and amniotic fluid volume with umbilical artery Doppler velocimetry. If mild or moderate gestational hypertension develops before this time, arrange this test and cardiotocography urgently whenever severe gestational hypertension is diagnosed. After birth, measure BP daily for the first 2 days after birth, at least once between day 3 and day 5, then as clinically indicated. Continue on antihypertensive medication, but reduce or stop if BP is seen to be falling, particularly if it falls below 130 to 80 mmHg. Switch women from meltidopa to an alternative within 2 days of delivery. Women with mild hypertension not requiring treatment during pregnancy should be started on antihypertensive medication postnatally if their BP is greater than 150 to 100 mmHg. Preeclampsia, hypertension with proteinuria and edema. Admit and monitor the patient in hospital. Always ask about headache and epigastric pain each time BP is taken to alert for any indication of progression towards eclampsia. Assess severity. Mild, 140 to 149/90 to 99 mmHg. Monitor BP at least 4 times per day. Twice weekly blood test for FBC, electrolyte, renal function, and LFTs. Moderate, 150 to 159/100 to 109 mmHg, or severe, greater than 160 to 110 mmHg. Monitor BP at least 4 times per day. Start labetalol or alternative to keep systolic BP less than 150 mmHg and diastolic BP between 80 to 100 mmHg. Blood test 3 times per week. Perform ultrasound examination to assess fetal growth and amniotic fluid volume with umbilical artery Doppler velocimetry and cardiotocography whenever preeclampsia is diagnosed. Repeat cardiotocography if there is a change in fetal movement, vaginal bleeding, abdominal pain, or deterioration in maternal condition. Preeclampsia will usually be managed conservatively, that is, without delivery of the baby, until at least 34 weeks. The management plan for delivery, including thresholds for early delivery, will be discussed with the parents on an individual basis and documented in the notes. Patients with mild or moderate preeclampsia are usually delivered between 34 to 36 weeks, depending on assessment of risk and availability of a special care baby unit, with fetal monitoring and after a course of corticosteroids to reduce the risk of infant respiratory distress syndrome, if appropriate. Signs of complications developing include headache, epigastric pain, papilledema, hepatic tenderness, signs of clonus greater than 3 beats, HELLP syndrome equals to hemolysis, EL, elevated liver enzymes, LP, low platelet count, platelet count falling below 100 times 10 degree L, abnormal liver enzymes, ALT or AST greater than 70 IU/L. Consider anticonvulsants, usually intravenous magnesium sulfate. Intrapartum, with mild and moderate hypertension, 140/90 to 159/109 mmHg, measure BP hourly. With more severe hypertension, measure continually. After birth, stop meltidopa if used within 2 days and avoid diuretics if breastfeeding, measuring BP at least 4 times daily whilst in hospital. Continue to ask about headaches and epigastric pain whenever BP is taken. Measure FBC, LFT, and creatinine 72 hours after birth and only repeat after this if abnormal. Step-down care, that is, to community midwives, when BP is less than 150 to 100 mmHg and blood tests are stable or improving without any pre-eclamptic symptoms. Reduce BP treatment. If BP falls to less than 130 to 80 mmHg, consider reducing. When less than 140 to 90 mmHg. Measure BP every 1 to 2 days for up to 2 weeks after transfer to community care for until antihypertensive treatment is stopped. Continue to monitor, that is, weekly, and arrange a medical review at 2 weeks postnatal if still requiring medication. Monitor BP at least until the 6-week check, where a urine dip should also be performed, and arrange repeat FBC, creatinine, and LFTs unless they have previously returned to normal. Prognosis. Hypertensive diseases of pregnancy remain the second leading cause of direct maternal death in the UK. However, most women with pre-existing mild to moderate hypertension, BP less than 160 to 110 mmHg, are at low risk of perinatal complications. The risks of complications, e.g., preeclampsia, placental abruption, impaired fetal growth, and premature birth, are increased in severe hypertension. Gestational hypertension. Similar risks to normotensive women, but 40% of those presenting before 34 weeks of gestation will go on to develop preeclampsia. Women who develop gestational hypertension or preeclampsia are at increased risk of hypertension, cardiovascular disease, and stroke in later adult life. Hypertensive disorders in pregnancy are an important risk factor for cardiovascular disease in women. Therefore, lifestyle modifications, regular BP control, and control of metabolic factors are recommended after delivery to avoid complications in subsequent pregnancies and to reduce maternal cardiovascular risk in the future. Prevention. Low-dose aspirin. See recommendation in high-risk groups as detailed under epidemiology above. Calcium supplementation appears to reduce the risk of high BP in pregnancy, particularly for women at high risk of gestational hypertension and in communities with low dietary calcium intake. Access severity. Mild 140 to 149 / 90 to 99 mmHg. Monitor BP at least 4 times per day. Twice weekly blood test for FBC, electrolytes, renal function, and LFTs. Moderate 150 to 159 / 100 to 109 mmHg, or severe greater than 160 / 110 mmHg. Monitor BP at least 4 times per day. Start labetalol or alternative to keep systolic BP less than 150 mmHg and diastolic BP between 80 to 100 mmHg. Blood test 3 times per week. Perform ultrasound examination to assess fetal growth and amniotic fluid volume with umbilical artery Doppler velocimetry and cardiotocography whenever preeclampsia is diagnosed. Repeat cardiotocography if there is a change in fetal movement, vaginal bleeding, abdominal pain, or deterioration in maternal condition. End of study session 9. Thanks for listening.